defining what it means to have a care omission in a nursing home. Stick around. Hey out there, welcome back to the podcast. My name is Rob. I will be your host. In this episode, we have a fascinating discussion about what it means for a nursing home to have an omission of care. What it means, like from a philosophical standpoint, what does being hurt mean? What does doing something improper mean? These type of things. But we're not doing it alone. We're doing it with a fantastic individual. Our guest this week is Dr. Yael Harris. I just call her Dr. Harris because I'm sure that I butchered that first name. But Dr. Harris and I are going to have a fantastic conversation about this specific topic. What are care omissions? How do we define that? Once we do define it, what does it actually mean and why is it important? All these things are discussed, and we're going to have a link in the show notes that for her article that she helped author a few years ago about this exact subject. So if you want to read more about that, follow that link and it, because it's a fascinating paper. But before we get into that discussion, it's time for the nursing home federal regulation question of the week, the quiz of the week. Under 42 USC 483.70, subsection D, who is ultimately responsible for making sure the facility has a QAPI program, a quality assurance performance improvement program? Is it A, the governing body, B, the administrator, or C, the corporate office? According to that specific federal regulation, it is in fact the governing body. It is the governing body that is responsible ultimately. The buck stops with the governing body to ensure that the facility has a QAPI program in place, that there's policies and procedures for that QAPI program, and that the QAPI program is actually implemented in fact. Give yourself 75 points if you got that right. If you got it wrong, better luck next week. All right, so now it is time for your favorite part of the Nursing Home Abuse Podcast, and that is the ChatGPT generated nursing home regulation joke of the week. That's where we take a specific regulation in the federal code and we say, hey, ChatGPT, can you make this funny? Almost certainly it is not going to be funny. We're going to continue this streak, but let's see how she did with 483.75. So let's see how we did.
The ChatGPT generated nursing home regulation joke of the week.
Skynet.
42 USC 483.75 demands quality improvement. Great. Let's start with the Wi-Fi so residents file complaints faster.
That was kind of funny. That was kind of funny. Maybe not for the appropriate reasons. I think there was a glitch in the system which made that funny, but still, I kind of dug it. So we're going to keep doing this until you tell me that we shouldn't be doing this anymore. All right, so enough of that. Let's get into the substance of the episode because, like I said, it's a fantastic discussion. So again, we don't do it alone. We have Dr. Harris with us today. Dr. Yael Harris, CEO of Laurel Health Advisors, LLC, leads a woman-owned small business dedicated to enhancing healthcare access and quality for vulnerable populations. With 9 years at the Centers for Medicare and Medicaid Services, she spearheaded nursing home quality improvement. Dr. Harris champions technology, particularly telehealth, to elevate health outcomes. Her impact contributions extend to diverse organizations such as the American Medical Association, AARP, and the United States Department of Health and Human Services. Holding a doctorate in public policy and a master's in public health, her research on nursing home care was funded by the United States Agency for Healthcare Research and Quality, and we are so happy to have her on the show. Dr. Harris, welcome to the show.
Thanks for having me.
So at the beginning of the episode, I talked about a an article, and that's how I found you, regarding omissions of care in nursing homes. And I was really interested to have you come onto the show and talk about what you found in your research and possibly how that can help our listener or our viewer with respect to them having a loved one in a nursing home. So just kind of, if you don't mind, how did that paper come to be? How did you come to participate in that? Why, kind of, what spawned that research that you conducted?
So, fortunately, I had the privilege of working for the Centers for Medicare and Medicaid Services a while ago and working on nursing home quality. So, privilege of working with entities across the country, working directly with ombudsmen, working directly with nursing homes, and advocates for families to find out what were the quality issues in nursing homes and how could they address them systematically. Were there issues that could really be addressed not individually, but restructuring processes, et cetera. I then went private and saw a solicitation from the federal government's the Agency for Healthcare Research and Quality, which was looking at this issue of what are omissions of care. And so I was fortunate to be able to do the work with a team of individuals, and also bring on a team of national experts to help advise us. And the goal of the project really was to standardize the definition of omissions of care. There were so many different understandings and omissions, I just, commissions, omissions, neglect. And we were trying to kind of ferret out the differences between the two, because until you really have a definition, you can't address a quality issue. So that was the main purpose of the paper, was to get national experts on agreement. This is what omissions of care means. And in the process, we identified a lot of things that would help nursing homes to improve their care.
So, just from a broad standpoint, we don't need to nerd out on the audience, but what was was there like a sample size? Was it like we looked at 1,000 different nursing homes with 10,000 different admissions or whatever? Can you just briefly and just from a large 40,000 foot view, how was the research conducted?
Sure, absolutely. So we did what's called a systematic literature review. So we looked through all the literature within a certain time frame that talked about omissions. It wasn't just restricted to nursing homes. We looked at omissions in any type of setting to look at the definition. And then we flagged the ones that were specific to nursing homes, and, so that those were more relevant than the other ones. Obviously, some things happen in hospitals that the same omission would happen. Sometimes it's a very, very different issue. So we really just wanted to understand how it's being defined and used across different types of literature. And then it was an iterative process in terms of developing the definition. So we went back and forth with literature, but we also had an expert panel that we consulted with. So we would share with them a draft definition, have a meeting, seek their feedback as a discussion, and then throughout the process, email them. So we met with them, I think, 3 times. We also were so fortunate to have a board of stakeholders representing everything from nursing home administrators to family members to patients themselves to ombudsmen. So really a broad group of people representing national organizations that represent nonprofit nursing homes. And we met with them at the beginning of the project to explain the nature of the project and see if there's any guidance that they had for us. And at the end of the project, we presented our findings and encouraged them to give us feedback, but also how could they use it? Would it be helpful for them in the work they do? So we came up with a final definition through that whole process. And the definition is: omissions of care in nursing homes encompass situations when care, either clinical or non-clinical, is not provided for a resident and results in additional monitoring or interventions or increases the risk of an undesirable or adverse physical, emotional, or psychosocial outcome for the resident. Kind of
Interesting.
wordy and lengthy.
Interesting. So I guess that, like, was there a lot of conflict between or not a lot of conflict? Was there conflict with respect to that definition? Like, how hard was it to get to? And that's a beautiful. I mean, that makes sense to me, the definition. But like, can you just kind of walk me through, like, what was the how did we like get to that? Was there somebody saying, well, it shouldn't be, something that's not clinical or whatever? Like, I guess maybe that's not a good question, but
No, that's a perfect question. Absolutely. But so that was the issue. Well, one of the first issues was when we talk about admissions, are we talking clinical? Because if someone has grooming and they expect to, have their grooming happen every day and it's not happening, that's care as well, and then if they're not getting, one-on-one time, that affects psychosocial, so there's all these factors. And so we said, this is about the resident as a whole. We always focus on person-centered care. And
Sure.
so what does the person need? And it's not just their clinical care, although that's critical. The other issue we thought about is the magnitude of the risk.
Hmm.
So there could be an omission that actually doesn't cause harm. There could be an omission that causes immediate harm with the omission. So I'll give you an example. If the resident's supposed to have a multivitamin every single day, and the CNA forgets it for a couple days, it's unlikely the patient's going to experience harm, but it's still an omission. The clinician has prescribed these medications for the resident because the resident needs these vitamins. However, if the CNA forgets to give them their Coumadin one single day, severe magnitude of an interaction. So we wanted to make sure that what we were defining is not the outcome, but the act itself that led to. So it doesn't necessarily need to lead to harm. It doesn't necessarily count when or how often the omissions happen. It's the fact that the person did not receive care that is, required for the individual.
That's an interesting point because I guess let's go back to the first example where someone might come in for respite care or we're talking about grooming or whatever. And let's say that personal hygiene isn't done for a couple of days. So that would be an omission. But there's no physical harm from most perspectives. However, I mean, I guess you could say that would be a harm to dignity as that's defined in the regulations, dignity and respect of the person. So there is an injury. But again, I guess it's just the perspective of how are we gonna define that? And I guess that's one of the many things that you had to tackle, which actually is a segue to I wanted to ask you is in your view, having looked at all this and having tussled with people on how to define these things, which is important. What do you think the difference is, if any, between omission of care as you've described it, and what we would typically colloquially think of as negligence, neglect? Like, what do you think the difference is between those two?
Absolutely. So I think the key distinction is harm. So neglect assumes there was a resulting harm to the patient, whether it's, as you mentioned, psychosocial, dignity, physical. There was actually harm to the patient,
Mhm.
and we think of neglect as intentional. Not just, oh, I forgot by accident, but I didn't have the time. I didn't get to this. Now, there isn't really a formal definition of neglect, and but with omissions, what we try to do is define it as it's not associated with the harm. It's not associated with the intent. It's associated with, did the act happen or not? And so one of the things I want to point out is that omissions of care cannot, it could be a larger issue. When you're neglecting someone, you're neglecting a person. You're not neglecting their care. You're neglecting their needs. With an omission, it could be something that is attributable to multiple factors. So let's go to COVID vaccines. This was actually developed before COVID, but during the COVID vaccination, a resident, did not get their vaccine. So there's a number of reasons for that. The CNA, or the nurse rather, never gave it to the resident, even though the resident requested it. The nurse couldn't get the vaccine because the physician never authorized the patient is safe to get the vaccine. It could be that the facility itself did not have enough vaccines in stock. They didn't expect that type of. And then lastly, and this is exactly what happened, it's system-wide in that there was a shortage of vaccines and we couldn't get them to the places, even though, the providers were saying, yes, unless it contraindicated, every single person in a nursing home should be getting a vaccine. So again, omissions, the same omission happened. The individual at the end, the resident, did not get the vaccine. Hopefully it did not result in a death, but that is the end result of the omission. Any of those things could have been what contributed to the omission, and only in one situation is really neglect.
I see. Because I know that to the extent that, like, for coming from where my perspective as an injury lawyer, that negligence in most jurisdictions requires damages. And if you don't have damage, meaning if there's no medical bill, if there's no literally physical injury, and we can't make the argument that there's an impact on dignity to the extent that it would justify the case, then you don't have neglect. Like, you don't, from a legal definition, pretty much. So that makes sense.
So in that case, I guess if the individual, the resident, didn't get their vaccination and ended up in the hospital,
Then
on a
that would
ventilator, there'd be reason to sue.
that's right.
However, if this patient didn't get their vaccination, fortunately, uh, you know, COVID was not brought in for, a smaller facility,
Sure.
they made proper habit. You would never even know the resident didn't get that, because there would be no clinical indication that it caused harm.
Right. Well, and some of those instances that you mentioned, you can only have neglect if there is a failure of the standard of care, and if there's a nationwide shortage, that's outside of the control of the facility. So yeah, okay. Um, all right. So let me ask this: like, so you've crunched all the data that it already existed. Was there any type of omission that seemed to be prevalent, that seemed to be more common than others?
So I would say delayed care was one of the most common. And so it was care that was not thought of at the time, but provided subsequently. In a lot of cases, those were not necessarily harmful, but it could have been, like the multivitamin. If I'd given the multivitamin 5 hours later, wouldn't be harmful. If I hadn't given the Coumadin on time, it could be pretty serious. Um, but these were also attributable to a number of factors. So, these were published articles. We couldn't go back to the researchers and talk to them one-on-one.
Right.
But we did talk to the expert panel who has been working in nursing homes for decades. And so I'll give you one example. If the person is at risk for pressure ulcers, the resident has, skin, risk of having skin integrity problems, and they're not turned, that's an omission. But is that neglect if the nursing home is short-staffed and there's not enough certified nurse assistants to manage? So while they're supposed to, turn this patient at this time, they had to go address another resident and meet another resident's needs, which are more, imperative. And so they turned the resident 2 hours later. Now that's enough for someone with really bad skin integrity for the ulcer to form. But while it was no omission, it was not a neglect. So, we tried to take the difference of, but it's a lot of times it's things that were pushed aside because of short resources or competing priorities.
That's an interesting point. So you've mentioned delayed care, and you gave an example of delayed care, the turning and repositioning. So would you say that your research kind of showed you that one of the primary drivers of delayed care was shortage on staffing, or some other more systemic cause, or not?
So this is personal versus from the literature itself, but having spent a long time working for the federal government on nursing home quality, I think there's two key challenges. And you'll see high quality nursing homes have this issue. One is having sufficient staff to meet the needs of the resident, and not blaming the nursing home. There's a lot of, turnover all over the industry right now, not just in medical care, but that's a challenge. The residents need care, they need around the clock care, they wouldn't be in a nursing home. And so making sure that there's sufficient staff to meet their needs. But then I know for a while the government talked about staffing ratios and they put in a certain cap. I don't think that's enough, because if you have a new person come in every 3 months, you're really spending all that time training them. They're not proficient. And especially when you look at the psychosocial, they don't know the resident. It's really important. This is a person you interact with every single day. You live in that nursing home. This is someone who's part of your daily life. you want a relationship with that person. You want that person to know your preferences. Like, I really like to sleep in and then get, bathed and showered at 10 as opposed to 7 in the morning. Like, you want that person to know your preferences. Even if they have enough sufficient staff, but that staff is turning over every 2, 3 months, you don't have that relationship. You don't have that collaboration. And there's things that don't go into your care plan, but that make part of your life. I mean, someone asked me, they're like, what if someone came in and brushed your teeth when you didn't want it? Just, it's very invasive. So you really want that relationship going. And so it doesn't matter if it's done at the same time every day. It's not an omission, but it's really not person-centered care. So there's an interplay there.
Sure. So I guess what I hear you say is that um, in your experience that staffing, whether it be turnover, training, not enough, these are the things that typically would lead to omissions versus somebody intentionally just not wanting to turn reposition or things like this. It's not as though in your experience people are just bad people. It's resources are stretched or there's not the opportunity to provide the person-centered care, in other words.
I'd like to think that, actually. I mean, as I always say, when you work in a nursing home, you could make more money working at McDonald's,
Mhm.
where they will actually fund your school care as well. So staff don't go to the nursing homes to work there because, I mean, it is a job, but they make a decision that they want to be in a field that's helping people. It's not an easy job. It doesn't pay any more than a daycare worker. So, to some extent, you've got to start by thinking these people are not ill-intentioned. That doesn't say everyone, but for the most part, no one goes into the situation being ill-intentioned. And part of the turnover rate is related to it's a very, very tough job. They may not get the support. I think one of the key things, and I'm glad you brought this up, is it's about the system itself and the support that the team needs. So when I was at the Center for Medicare and Medicaid Services, we always talked about person-centered care and holistic care and consistent assignment. And by that, we meant I have the same nurse, CNA, working with me daily. I'll be sexist and say she knows my needs, knows my understanding. We have a relationship and understanding. Um, if she forgets something, it's because she's distracted, like, not she has ill intent. That
Right.
I'm not going to say that happens all the time. But the big issue is if she forgets something, there's a blame and accusatory, negative implications. Whereas it could have been, you know, it's an omission. It's not an intentional omission, in which case the good nursing homes are learning institutions. They're always looking at how can we improve? What did we do that we could do better? And so this is true in hospitals too. If you have an open policy where people can report omissions without getting penalized, and in some ways almost, not applaud them for the omission, but applaud them for the honesty,
Sure.
it allows you to look at, are there systematic issues going on? For example, I couldn't get there because I had 10 patients to take care of when I'm only supposed to have 8. Well, then we know that's a consistent problem. This is happening over and over again. It's an issue that the nursing home can address. If it's an issue where, the nurse gets distracted, how do we help? What do you need? What tools do you need to make sure that all these care happen? So I'm not saying it's not, there are no malicious intents. There could be, but for the most part, I think people who go into nursing homes want to do the right thing, and they need to be able to not be afraid to share when they need help identifying how to improve their processes.
What do you think are the results of your research on in this paper? Like, what were the implications, like, or what did you intend the implications to be? And do you think that they were met? Like, in other words, like, all right, we have the definition of omission. Now what? Like, what are the next steps once we have, okay, we've decided that intention isn't important. It's just whether or not this care was left out, et cetera, et cetera. What are the next steps?
So that's a great question. I think the initial reason the federal government funded this was to have a standardized definition to evaluate issues in nursing homes. So the really goal was to have a standardized definition so that you could separate action and inaction from the outcome. And you also could destigmatize omissions so they can be better detected. So omission is not neglect, and omission is, something that could be addressed, or was inadvertent, or it could be advertent. And you could also use this definition to conduct root cause analysis. So as I talked about earlier, finding out if there's really a pattern. And so having a standardized definition helps you to get here. The other thing that I really found that I really enjoyed working on, which aligns with my passion, is trying to identify omissions also took into account identifying care. What is care? Is it the care plan? No, it's not always documented in the care plan. It's not just clinical care. I mean, there's more harms, but psychosocial harms are pretty extensive. This is their home. They live there. There needs to be a matter of respect and dignity and accommodating preferences. And so that is still part of an omission if that's neglected. Someone says, I need help getting dressed, and the help doesn't come, that's still an omission. And then the other issue that we talked about was commission versus omission. So, someone got the wrong med. Is that neglect? Is it an omission? And we define that as a commission. So in other words, there was an omission in that the person didn't get the right med, but getting the wrong med was not an omission. It was a commission. So I think it really helped us kind of distinguish from, as you said, neglect to omission. So rather than going into nursing homes assuming bad actors, it allows you to go in and look at, what processes can be improved and how do we measure differences across nursing homes. So it's kind of the glass half full versus glass half empty approach. And without that standard definition, it's easy just to assume everyone is a bad actor.
So right. I guess this would make theoretically the QAPI process, the quality assurance performance review process, somewhat more efficient, somewhat more able to respond to the specific issues they're having if we've defined, okay, this is what's going on. And even specifically to your points of like, okay, you might not have done this, your mens rea might not have been intentional, but is this systemic? Is this just, Nurse Jane Smith doing this? Like, how can we approach this from a facility wide level and change things? Well, that makes a lot of sense. Dr. Harris, this has been a fantastic conversation, and I really very much appreciate you coming on and talking to us about this. It's almost like I said at the top of the show, it's almost like a philosophical discussion. Like this is like a philosophy, like what does it mean to have been harmed? What does it mean to, what does clinical care mean for us? But these are all important questions because it drives what we are going to do in the real world. So I really appreciate you coming on.
Thank you. And thank you to all of your listeners for the work they do. It's very important that we take into account our older adults for the most part, and that we're recognizing their needs and meeting their needs. They're very important parts of our community. And so thank you for doing this.
Excellent. All right. Well, I hope that you enjoyed the content of this episode. A new episode of the Nursing Home Abuse Podcast is published every single Monday. We are back to a once a week schedule after, a couple year break. So hope that you're enjoying it. Again, we're shaking the cobwebs off. All this is new. The world has changed in the 2 or 3 years since we've been doing this. So hopefully we're just getting the kinks out and getting our sea legs, for lack of a better word. And with any luck, the episodes will get better and better. But who knows? Maybe not. And if not, hey, go listen to the Joe Rogan podcast or something. Just kidding. But not kidding. I guess it's good. I don't know. I haven't watched that in a while. Anyway, with that, everybody, we'll see you next week. Thanks for tuning in to the Nursing Home Abuse Podcast. Nothing said on this podcast, either by the host or the guest, should be construed as legal or medical advice, nor is intended to create an attorney-client relationship between the host or their guest and the listener. New episodes, for now, are available every other Monday on Spotify, Apple Podcasts, or on your favorite podcast app, as well as on YouTube and our website, nursinghomeabusepodcast.com. Again, that's nursinghomeabusepodcast.com. See you next time.